The visual diagnosis part 1. So we have 5 cases. Let's see if we can get to all of them. We certainly can get to a few. The first one is, okay, here, what's the case here? I have it here somewhere. Child presents with pain. It's a 3-year-old, has pain, and vomits this stuff that you can't look at mine because my printer.
It's supposed to be green.
Printed the wrong color. So what's going on here? It's bilious.
Bilious
okay,
vomit.
It's green. That's the important part. So what does bilious mean? Bilious means bad. It means it's ligament of distal, bad, and usually obstruction. And in this age group, what are causes of obstruction? What causes obstruction in a 3-year-old? Malrotation, big one. But there's a few things that can. But just, you don't have to know what it is. You just have to know it's bad. If they have bilious vomiting in a little child, this is somebody who has something that's serious going on, needs a surgical consult, period. Easy.
Can I make a point, though?
You may.
Malrotation of the gut is usually identified pretty early on in the life of a child, but it doesn't have to result into problems until a 1 or 2-year-old. That would be unusual, but that's why this is a case.
Yeah. So as we go through these, there are some of the details of these cases that Rick wrote that did happen, apparently. They are real cases, but they're sort of misleading. So this is usually in much younger kids.
Right.
Okay. So number 2, so anything else to say about that? I think that's really pretty straightforward.
Well,
Lots of reasons kids vomit, from very bad to minimal, from GI tract to brain to systemic disease. That's a whole different discussion. But bilious vomiting should be easy. It's really easy.
Projectile vomiting, we know that one.
Yeah.
I'm going to give you give me another cause of vomiting in children that would be other than some kind of infection or something like that. Some nasty one. Give me a nasty one.
You give us.
What's that?
Shaken baby. Sure, brain.
Have you been reading? I think you've been reading ahead, doctor.
I'm studying for the board.
I was going to say that's exactly right. And shaken baby, and that's one of the. And who is the shaker of the shaken baby? The boyfriend. The mother's boyfriend.
Okay.
Did you know all this?
Of course, I know that. Unless it's not the mother's boyfriend. It could be the mother. It could be
It's the mother's boyfriend.
Husband. It could be all sorts of people, but it's often the boyfriend. Who else? What else? Metabolic causes, right? Kids who are metabolically abnormal. Vomiting is an expression of that. Kids who have minor head trauma. In fact, the most common cause of vomiting in a child is you looked at them funny. Kid, that's the universal response to I'm upset is vomiting in child. But some of them are really sick, so just keep that in mind. Okay, anything more you want to say? Anecdotal stuff that's meaningless? You want to say any more?
Nothing I'm saying is meaningless.
Okay.
All right, if you want to, if that's the best you can do for that case.
Number 2. What does this EKG show? Again, my printer doesn't have anything on it, so that won't help. So help me out. Look at the EKG and tell me what it shows.
But look at the age of the patient.
Okay, look at the age. What's the age of the patient?
It's young.
Okay, this is a really bad case, Rick.
This is a real case.
I know, but it's misleading. Anecdotal stuff can be really misleading. This is totally misleading.
This is a real.
So it's a real case who has this weird thing that follows my rule of case reports. I've actually published this. When you read a case report, so who's ever read a case report that says, we had a patient in the ER, he was acting really wild, and then we did a diagnostic test and he turned out to be drunk. Have you ever read a case report like that? Why wouldn't you ever read a case report like that? Because it happens all the time. You don't get to publish a case report unless it never happens, right? Something really weird, that's when they publish a case report. So my rule of case reports is never pay attention to case reports.
But this case talks about some interesting stuff.
Because they're so weird that they never happen. It probably didn't really happen in the case that's being reported. And if it did, it only happens 1 in a million. It already happened. It'll never happen to you. So for the most part, this is a real case,
All right,
but you will never see this case.
This is a patient with chest pain, a young person. What do you see on the EKG?
That's the important part is the EKG. Forget all this other stuff of this weird case that never will happen again.
So what do you see on the EKG?
The elevations and the depression.
On every lead? So what do you think? This is a board EKG for sure.
So I'm seeing a lot of big time ST depression in V1, V2, V3. Through actually most of the V leads.
So this is a chest pain patient who's got.
So what do you worry about if you see big time ST depression anteriorly in the EKG?
So this is a true posterior MI.
Okay, great. So remember that you can't see ST elevation in the back of the heart because the leads are in the wrong place. The only way you could see it is if you put the leads on in the back, because ST elevation has to be coming towards you. So if it's going away from you, you see the opposite. So the reason you can have ST depression in the anterior leads is either because it's reciprocal changes. So you often see it in an inferior MI where there's reciprocal changes, you see it. Or the other reason, if you're not seeing inferior ST elevation, is a true posterior MI. Both of them, what's important about an inferior or a posterior MI is the source of the coronary artery that's failing. Which one is it? It's often the right. For inferior MIs, it may be the left, but it can be the right. What's special about right coronary artery? They're volume dependent. So the worst thing
Nitroglycerin.
So there you go.
That's the answer.
So if you give them nitroglycerin, they can get hypotensive. So
And
that's
basically, if you take that V1 and spin it 180 degrees on its axis, you'll have a classic picture of a anterior MI.
so you do it like in a mirror.
It's a mirror.
So let me ask you this. So if somebody is hypotensive and they have an MI, there's two possibilities. Well, there's a bunch of possibilities, but if it's due to the MI, if it's not from an arrhythmia or some other reason, it could either be because they have left-sided pump failure, right? If they have left-sided pump failure, how will you know that? Their lungs are full,
Yes,
right?
they're not breathing.
They're having trouble, so they have both forward failure and backward failure, and those people are called
Cardiogenic
cardiogenic
shock.
shock, and that means they're dead, okay? It doesn't matter what you do, don't worry. You can't make it worse. You pretend the opposite, but that's really true. Unfortunately, nothing works for that. Or it could be that it's just volume dependent right-sided, and they may have normal fluid volume, it's just not, the right side isn't pumping, so the left side is volume depleted relatively, and that's why it is. So you give them more volume and you make them better. The key is clear lungs.
Clear lungs.
But one of the ways in which you know that, you might know that is they started out looking not hypotensive, but you gave them some nitrate, you vasodilate them, and boom, they now become hypotensive. So if you give somebody nitroglycerin and they become hypotensive, there are two things that can happen. One is this. What's the other one? One is that they get volume, they're volume dependent and you deplete them, you vasodilate them. The other is it's just a vagal response. Nitroglycerin causes a vagal response in about 15% of people who get it, and they'll become hypotensive. How can you tell the difference between the two? One of them is volume dependent, so they go fast. They become tachycardic. That's the one you give fluids. The other one, if it's vagal, they'll go slow. And the good news with that is if you need to give them a nitrate because they're, for whatever reason, they're having some failure or whatever, and they become hypotensive, if it's from a vagal response, just wait 5 minutes and then start up again and they'll do fine.
And if it's from Viagra on board?
Viagra on board. And then you cross the international date line and you add this complication and that complication.
So I don't
Fluid.
actually know how to answer that.
Fluid.
Because there's actually no literature on Viagra effects of that. But yes, probably a little fluid, yeah. Okay, so...
Now, why did this young person have this problem?
So why did he make up this case?
Is it an anomaly? I mean, I had a case.
Well, take a look at the angiogram. There's an angiogram picture on the answer page. On the answer page, which is, tell us where the, you see, there you go. What page is that, doctor? 284. So there's an angiogram. Looks like a weird coronary artery. Would you not acknowledge that? And we're talking about a 28-some-year-old person with a
So
weird
why do
coronary
young people sometimes
dilated.
have coronary artery aneurysms? What's the famous cause of a coronary artery aneurysm in a young person?
Because we missed the
That's
diagnosis
the
of
reason you could have it. Could have it from trauma, but the other reason is Kawasaki's.
So we missed the diagnosis of Kawasaki's in a young child, and this is one of the consequences. So now we're going to talk about Kawasaki's disease.
Okay,
See how this works, Jerry? It goes from one thing to the other to the other.
Okay, so what do you need to know? What is Kawasaki's disease?
It's one of the few diseases that you need to pick up, actually.
What's Kawasaki's disease? What's the other name for it?
Muco.
MCLNS. What's that?
Muco.
Mucocutaneous lymph node syndrome. So that's most of it, right? So they get big nodes, they get mucus involvement, tongue as well, get a red tongue. Their hands and so why is that wrong? Hands and palms and soles get desquamate. Why shouldn't I say that?
It's a late finding. I'm helping you, Jerry. I'm trying to help you.
I don't want you to answer the question.
Well, we got to get through this, you know? Time's running up.
I wouldn't even have talked about Kawasaki's if you hadn't made me. Okay.
I'm watching how you do this, Jerry.
You're not watching. You're. Okay, yes, they do desquamate. But that's a late finding. If you wait till then to figure it out, that's too late. So early on, they get mucous membrane involvement. They get a rash all over the place, erythematous rash. They get the tongue is involved, strawberry tongue. Their eyes get involved. Looks like measles used to be. And later on, they will desquamate in their hands. But so just know this: febrile illness in little kids, something to think about. Anytime you involve mucous membranes or palms and soles, that's the most important clues to this rashes matters. We see a million rashes. Do you know what they are most of the time when somebody comes in? I don't know what they are. The vast majority I don't know, and I don't care. When should you worry? They're really, really sick. You know, it's all over their body and they're weeping and they're losing fluids. Or it involves the palms and soles. That's when you should worry. Or it involves the mucous membranes.
Stop talking. We need new batteries. While Jerry's being recharged here.
Okay.
Yeah,
anything
palms
else you
and soles
want to say?
rashes is basically another thing that they talk about in the board exams. So what other things cause palms and soles rashes? Syphilis, yeah, right. That's right. That causes this person's problem.
Yeah, and also sepsis. Hand, foot, and mouth is one of the few unimportant ones. But sepsis and all of these things like toxic shock syndrome and staphylococcal sepsis, skin syndrome, all of those palms and soles. So you see palms and soles, you see mucous membranes involved, you see the mouth involved. Those are the ones where we have to be concerned.
Yeah.
RMSP, exactly right. Exactly right. But actually any of the sepsis can do it, and that's why Rocky Mountain does it. It's a form of, it's a very, very similar in terms of its immunological.
You know, the reason I put that disorder in there is because it's one of the few pediatric fevers that you really need to kind of try to diagnose, because there is a treatment that they give these people to try to prevent this. The vast majority of other viral illnesses is going to get better no matter what you do, and just don't get in the way.
Okay, are we done with that one?
Yes, we are.
Okay, number 4. Somebody look at number 4 and tell me what it is and how we know.
What's the question?
And so the question, did we do 3? Oh, 3, sorry, my apologies. Number 3 is here somewhere. I got it somewhere. No, I don't have it. I lost my thing. So number 3, somebody read it for us. A attended patient is brought in to the ER. He's homeless, unable to provide any medical history. He has medicines with him, of course. And for some reason, the triage nurse orders an x-ray of the right shoulder because you have a triage system which orders all sorts of unnecessary tests.
Actually, I made a mistake. It's really the left shoulder.
Whatever it is, let's forget the case. You get this x-ray. What is it? How do you know? And what other things should you think about? So it's the shoulder. There's something going on in the shoulder. What's going on? It's dislocated, is it? How do you know? It looks funny. What looks funny about it? It looks like a light bulb.
Light bulb.
What's wrong with a light bulb? It's nice and smooth. You should have a divot where the lesser trochanter is. This looks like a light bulb means it's not in the right place or it's turned, and that's exactly what it is. And where is it dislocated? Posteriorly. This is not how you should diagnose it. You see this, you should say, ooh, that might be funny, and now you should get an axial view or a shoulder view or some other view that will show you where the dislocation is. But this should be a clue about it. What else do you need to know about posterior dislocations? They're uncommon. What else? Seizures is the usual cause, is one of the most common causes. So if you find medicines, it's probably going to be a seizure medicine. It might be why the patient's a little obtunded. And how do you treat it? You don't do any of these techniques. Those techniques are all designed, external rotation, abduction, are all designed to move the thing anteriorly to get it freed up from where it's stuck here, and so that it can then pop into the glenoid space. That won't work if it's in the back. So traction is the way to treat this.
The old-fashioned way, just pull on it.
You guys done this, seen these? They're not that common, but I'm sure you've all seen them.
That's a test question too also, doctor. Posterior dislocation.
I've been working hard.
Yeah, you have. It's very clear.
How about number 4? This is a really bad question. Don't tell Rick I said that. Number 4 is a previously uninsured 25-year-old male, now has health insurance. He's been having headaches for several months. He now presents first time bilateral intermittent, improve with analgesics but recur. You can also tell me when they recur, because it's not written on here, but we can figure it out. He otherwise is normal on his exam. His mentation's normal. He casually mentions that he has a noise in his ears. So what does the CT scan show, and what is wrong with the CT scan?
It's only one view.
Okay, let's assume that other views add no information. It looks how? It looks fine. So what's wrong with it? Why was this CT scan done? It should never have been done. What should have been done instead? So let's change this from a 20-year-old male and Rick's cockamamie story. Let's make it a young woman who is a little bit obese and is...
Well, that's the whole point. This is not limited to young obese women.
Okay, so what do you need to do?
10%.
And let's assume that it's worse in the morning and worse when she bends down, and a little better during the day.
Benign intracranial.
So benign intracranial hypertension almost always occurs, not always, nothing is always, in young women. It's usually in people who are obese.
Little
often
chubby.
related to pregnancy, but not always. And the key is headaches that have been going on for a long time and are gradually getting worse, sometimes have eye findings. That's too late if you have eye findings. You want to diagnose it before then. They sometimes complain about tinnitus all the time. And the big thing is that it gets worse when you raise your pressure in your brain. So how do you raise your ICP? You Valsalva. So when you go to the bathroom, she may complain that when I have strain at stool, it hurts. What else? You cough. Okay, what are the other things that we all do that happen all the time? Bend over, tie your shoes. Most people don't say this, but if they do say any of those things, you got to say, oh, ICP headache. That's the key. And there's one thing that we all do that raises your ICP every single day. What's that? Go to sleep. When you go to sleep, you lie flat for several hours. Your ICP goes up. And you do one other thing when you sleep that makes your ICP go up.
You don't breathe.
You hypoventilate. So the classic story of an ICP headache is wakes you up at 4 in the morning, where you've now been sleeping for a long time and hypoventilating. It finally wakes you up. You get up, you're really nauseated, maybe you vomit, you hyperventilate, and you feel better. That's the classic textbook ICP headache. Most people don't have it, but if they do have any of those things, worry about ICP. The key is this person doesn't need a CT scan, they need a fundus exam.
That's one of the parts that says, what is the missing part of this exam? It was the fundoscopic exam.
Okay, and number 5, what's number 5? Number 5 is a 59-year-old man has another wacky story. Jesus, Rick. The man has hemiplegia. Okay, he's got hemiplegia, and it happened while he was skeet shooting. Can we ignore that for a second? Let's not make it skeet shooting, because you will never see this happen with skeet shooting.
Real case.
It's already happened. It will never happen again. Okay? Let's make it, and this time, instead of you got a chest x-ray, which happens to be abnormal, let's assume that this person who has hemiplegia also has chest pain, because that's the much more common thing. What should you be thinking?
Chest pain too.
What should you be thinking if somebody has neurologic findings and chest pain? Well, let me put it different. Okay, how about if I say this? He doesn't have chest pain. He has a cold leg. So what should you always be thinking if somebody has two different organ systems involved? There's got to be a central source to it. And what are the possible central sources? The aorta, and what else? The heart. So the reason that people have acute onset of two different major organ systems that are arterially perfused is because they either have a tear in the aorta, an aneurysm that's a dissection in their aorta, or because they're flipping clots from their heart. They have AFib. They just went into AFib and they're flipping little clots. Or they have a coronary aneurysm. They have a myocardial aneurysm from some other thing and it built up some clots and now they're flipping them. Or they have sepsis and it involves their aortic valve and they're flipping clots. But whenever you have two organ systems, you got to think about the heart or the aorta. And then you go look for it. And in this case, what's wrong with the EKG? With the chest x-ray? The aortic knob looks funny. Does it look funny? Yeah, it does, right? Mediastinum looks funny. So the good news is that almost always the mediastinum will look funny. It's not 100% sensitive, but very, very highly sensitive. It's not specific. There's a million reasons why your mediastinum can look funny, but it's usually pretty sensitive. But in any case, I don't care what the chest x-ray shows. If you have two organ systems involved, it is your heart or your aorta. And then you figure out which one it is. Right? Make sense?
Are there any other questions associated with this wonderful case?
And he was skeet shooting because this was a traumatic dissection of his. Oh my God.
It's the truth, man.
Jeez.
You don't want to listen to the truth, you know? Anything else in that case?
I'm done.
Were there any other
Was
questions here?
I thought that was pretty good.
That was a pretty horrible half hour. All right, guys. We'll
We'll see you guys tomorrow.
we'll see you tomorrow.